the incarceration cost that skyrocketed in your county as a result of opiate addiction, as a result of the opiate addiction epidemic?
Chairman Kucinich, we've been hit by a tidal wave of opiate addiction in central and southern Ohio. Initial...
Let me just stop you there. Why? I mean, aside from the obvious, why?
I can speculate. I think it really it goes back to three things. We have a tremendous number of opiates coming up from Florida and Kentucky and Portsmouth, Ohio. We have heroin from Mexico coming in from Columbus. But from my perspective, the big problem is an unsuspecting healthcare community that is just inundating our part of the state with unnecessary and inappropriate levels of prescription painkillers. Again, 13.9 million doses of oxycodone and hydrocodone products alone across a population of 269,000 people. That's 52 doses for every man, woman, and child that lives in those four counties. It's staggering. I think we're at the tip of the sword. I think this problem...
who's consuming these?
I'm sorry, say again, please.
Who's consuming these?
I think that we probably have I think we could have...
it's not every man, woman, and child, so who's consuming them?
I think we probably have several thousand people in our area, in Fairfield County maybe, that are opiate addicted, that are still not known to our system.
So somebody who's opiate addicted, how many of those might one addict take in a day?
Well, that's a great question, and probably some clinical experts could answer that better than me, but what we do know is, or what I do know from discussions with a good friend of mine, Dr. Philip Pryor, an addictionologist, that as human beings we have an almost unlimited ability or capacity to tolerate opiates. If you look at the tolerance levels for alcohol, the ratio is about 4 to 1. An early stage alcoholic can drink about a 6-pack a day and get what they need. Late stage alcoholic may drink a case. But if you look at opiate addiction, an early stage opiate addict may use 60 milligrams a day, but a late stage opiate heroin addict may be using the equivalent of 1 to 2,000 milligrams of heroin. That's a 70 to 1 ratio.
Mr. Mavromatis, can your personal experience shed some light on this in terms of the volume of a particular drug?
If you look at the shorter acting opiates that are pharmaceutical, like Vicodin, Percodan, Percocet, things like that, the range is pretty broad, but it can be anywhere from 20, 25 tablets per day to what I was consuming, up to 100 or more.
25 tablets at what dose?
5 milligram to 10 milligram.
When you were moving into this addiction, were you aware that you were doing that?
No. It was a slow and unsuspecting process. I went to the doctor. I did everything the doctor asked me to do. I was always honest with the doctor. And my decline in life, I guess my personal life, my emotional life was slow too. I was slowly becoming detached from my business, from my family, from my community, from things that I always did, things that I loved to do. What I didn't realize at the time is my body's building a tolerance. So when the doctor asked me, Mike, how do you feel? Well, doc, I feel pretty good, but the sciatic nerve's starting to act up again. And there went the process, until I realized I had a problem.
During that period, you said you put on weight, so you ate more. It increased your appetite. Is that right? Or did you just put on weight?
I don't think it was so much Mike likes to eat, and being in the restaurant and being Greek, obviously, but I don't think it was that. I think it was more being detached,
Really?
Slowing down. Instead of spending 14 hours a day in the business 6 days a week, you know what I mean? It's a slow decline. Instead of coaching 3 junior high school sports, all of a sudden you're coaching 1,
so it's a withdrawal from
Exactly.
work and
A withdrawal from normalcy, I guess, is a good way to describe it. And by the winter of '03, '04, when I decided, you have a problem and you need to start figuring out what it is, so I started the process of elimination. What has changed? My weight increased up to, somewhere between 255, 265, something like that. And that's when I decided, it has to be the medications you're taking, so stop taking them. And that's when reality hit me in the face.
back to Mr. Hall. Tell me more about the extraordinary level of consumption of these opiates that is going on. Talk to me more about that. What do you?
To be completely honest, Mr. Chairman, the data is still that we have is still unfolding. I don't know that we can estimate with any clear sense how many people there are in our county that are affected, given the tolerance ratios. We fear that we fear that there could be several thousand people in Fairfield County alone. We know that there are many counties to the south of us that have even worse problems than we do.
Are you laying the groundwork for epidemiological studies or for longitudinal studies that would try to see any other markers or indices that would reflect upon this staggering amount of drug use?
Yes, sir. We desperately need that type of work. We've conducted some opinion surveys in our county that are also quite disturbing. A survey of 350 Fairfield County adults indicated that around 78% of the people that responded were aware of someone in their immediate family or among their friends that had received an opiate prescription within the past year. 22% were aware of someone that was using an opiate prescription an opiate painkiller without a prescription. So it appears to me that the problem is fairly widespread in our area, and those counties immediately to the south of us appear to have a bigger problem than we do.
And these are prescriptions as opposed to black market?
I think it's a mix. It's hard to discern the degree to which they are prescribed as opposed to coming in illicitly. What we do know, there is an anesthesiologist in our community that is beginning to do some research about diversion, and he believes that among those patients in his practice that are receiving opiate prescriptions, that maybe as much as 20% of those prescriptions are being diverted for illicit use.
Let me ask Mr. Mavromatis again. As you were sliding into this addiction, what kind of feeling did you get? I mean, what did these opiates do for you?
That's what it was deceiving. You know, I was prescribed Vicodin for pain, and I took it. And other than helping me with the pain, I didn't have any other sensation. I didn't have a high sensation. You know, when I was young, fresh out of high school, and you'd go out and have a few drinks and have a good time, or whatever you might partake in, I knew what feeling high was.
So for you, this wasn't about getting high. It was about what, pain relief?
Oh, absolutely. Yeah, I had injured myself remodeling our restaurant, and I had done damage to the L5 disc in my back, and that's been a slow progression, you know.
So if you took the drug, you didn't have pain, but you kept taking it and you got addicted.
Right, and as I would time would go on, evidently the tolerance to the medication would build, so the pain would start to creep back in. The doctor says, "Mike, how you feeling?" I'd tell him honestly, you know, either I was great or, "Doc, you know, the sciatic nerve starting to act up again, you know, or you know, I'm having trouble with getting up with muscle spasms or aches in the middle of the night or whatever, so up the dose."
You know, this discussion previous panel, we got into this too with Mr. Kennedy's help. Getting into the area of effective pain management, non-narcotic approaches, if they can be effective, that non-narcotic, non-addictive approaches. It's pain management's a whole area of medicine that I suppose needs to be mindful of the kind of discussion we're having today. Now, someone had his hand up that wanted to get Mr. Warren. You wanted to enter into this discussion?
This issue of what's driving the drug trade, prescription drugs, was sort of the interchange that I wanted to respond to. We have a very large market that's well known, Lexington Market in Baltimore City, and it's an area of our city that numerous high-profile individuals want to redevelop. And so the theory was that, well, there are methadone clients or buprenorphine clients that are going there and selling their drugs, and that's why you have an open-air drug market around that market. Well, what we did was for 6 months we monitored who was arrested at that market, and at the same time looked at who showed up at the detention center. And so what we found was that a minuscule, like 2-3% of people being arrested were in drug treatment, and they were not there selling their methadone or selling their buprenorphine. What they were there was people were there selling prescription full agonist drugs, the Percocet, Percodan, Vicodin, and where they got those prescriptions is up to conjecture. My hunch is they were taking from their grandmother, their parents, their relatives' medicine cabinets, and going down and selling some of that prescription drugs that people take for legitimate pain medication, and there needs to be a significant physician awareness campaign that they need to improve their monitoring of the prescriptions that they're giving to individuals, because that was what was driving the drug trade in this particular area of Baltimore City.
Mr. O'Keefe and Mr. Pops, how critical was the NIH funding and support to both your company's development of Suboxone and Vivitrol? Is there a strong case for continued federal funding and research on medications development to create progress in this area? Mr. O'Keefe.
It was absolutely crucial for Suboxone. It would not have happened without Suboxone, without research from NIDA. And a series of things had to happen. There had to be some exclusivity. There had to be approval by the FDA, and there had to be funding from NIDA.
Now, before we go to Mr. Pops, I just want to ask you as a follow-up. You stated that the failure of the FDA to take a position on what constitutes efficacy in clinical trials for addiction is a major deterrent to investment in research on these products.
It is a major deterrent. FDA has not decided yet how they want to measure the efficacy of drugs. For example, if a pharmaceutical company had a new product for the treatment of opiate dependence, opiate dependence may be a different story. Let's look at something like for which there is no treatment, like methamphetamine. The FDA cannot yet decide whether a reduction in use of methamphetamine is a measure of efficacy, or whether total abstention from methamphetamine is the mark that they would put on the chart for efficacy. And until that happens, no pharmaceutical company is going to spend a great deal of money if they don't know what the end is for them to research. So that's one of the major problems of deterrence to development, to interest of pharmaceutical companies.
Mr. Pops.
So similarly, the NIDA funding was important NIDA had been calling for literally 30 years for the development of a long-acting injectable form of an opioid receptor antagonist. And it really took until our technology became available for us to make that happen. So the seed funding was important, but it's important to recognize, to the bigger question, that we probably had to come up with another couple $100 million on top of that to develop the drug. And I would say that today, NIDA's voice amplifying and underscoring the importance of the data that resulted from clinical trials is extremely important at this moment. So it wasn't just at the beginning, it's throughout the entire process based on the quality of the data that comes from the research.
Thank you. Dr. Samet, our subcommittee has found, and Mr. O'Keefe testified, that one of the reasons doctors are hesitant to treat patients who are addicted to drugs with medications is because of the scrutiny it brings from the Drug Enforcement Agency, which regulates opiate-based medications. Have you found this to be true in your work and your involvement with the American Society of Addiction Medicine?
Actually, I'm probably one of the few docs that had the DEA come by and say, we want to check what you're doing. I think it's likely more perception than reality. Docs are concerned because DEA can make your life difficult. But docs who are using Suboxone in fairly established, agreed upon approaches with patients, in truth, don't have a lot to worry about, would be the way I'd put it. I can speak from my one situation where what they asked for, we gave them, they said, good work. But there is that perception.
Is there any, I just want to go down the line here, starting with Mr. Mavromatis. Is there anything that you'd like to say to the subcommittee for the record with respect to the direction that you think we should be taking and looking at for the purposes of having a more effective national drug policy? Mr. Mavromatis, and then we'll go right down the line. You can just take a minute. Go ahead.
Thank you. I can use Suboxone as the example because that's what I know. With Suboxone, unlike the older recovery medications, you actually have a medication that is proactive and productive and fosters and lends itself to recovery, yet it has restrictions on it that are counterproductive. So when I go to help people, or my peers, so to speak, find doctors and find help, it's not there. A doctor prescribing Suboxone can only prescribe to 100 patients, and then when I look at it in what people are paying in our area in Columbus, we're blessed to have a lot of doctors prescribing. In other parts of Ohio, for instance, where there aren't any, the expense is night and day. Competition brings the price down. I think there's like overall maybe 1% doctors willing to prescribe. So I think my feeling from my point of view is if whatever you do, use the gains we now have, and we're going to have more with medical science, to be more productive and more proactive, and take that education and group it, blend it with the education of old, the peer support, the spiritual, and all that. So we're moving forward instead of doing little things that with each step we take forward, we're backing up a step or half step.
Thank you. Dr. Samet.
Thank you for the opportunity. Thank you for the opportunity to reflect on that. I think that with more medications available to treat addictions, more patients will be treated. A few medications can treat a sizable number. The more you have, the more options to include those patients who don't succeed first time around. But that's going to also require training physicians and nurses to know how to treat patients for these problems, to understand these problems. It hasn't been traditionally part of the curriculum, but it's becoming, and that needs to be encouraged. Finally, because, as you heard from Dr. McClellan, the substance use treatment system began independent of the medical system, more coordinating care between that system and the medical system is critical, both communication at every level, and really the time has come to make the treatment of addictions a mainstream medical issue, in part so that we help people with those problems, and in part so that we can treat everything else that's going on, because if we don't, that's not possible.
Thank you, Mr. Warren.
Yeah, thank you for the opportunity to share on this important point. I would say three things. First, buprenorphine has enabled us to establish relationships with other parts of the healthcare system that heretofore we've had no contact with. FQHCs, hospitals, primary care physicians. It creates, I believe, the foundation of learning that we'll need when national healthcare reform hits in 2014 and beyond. The second thing that I think really needs to be stressed about Suboxone is Suboxone doesn't cure anybody. It simply provides the opportunity to help. It provides us the leverage to make amends for bankrupt educational systems, social support networks, and so forth that need to be created for these individuals that have never had this support before, and it gives us the time to develop it. That's the important thing. The second piece is, if we want to make a difference in crime in this country, we have to realize that drug addiction drives crime. If we can offer an intervention that allows, in the conversation I had with our police commissioner the other day, he said the two biggest things you could give a police officer would be, here's a card you can give somebody to get a job, and here's a card to give somebody so they can get help for their drug treatment. The people who cause us the most angst in the communities in which we live are the people suffering from addiction. And creative uses of drug court, detention centers, and the prison system to help people, I think, will make a big difference. I started a therapeutic community in one institution. I went to graduation. This gentleman came up to me and says, hey, last 6 months have been great. I've learned so much, but listen, I know I'm about to be released in about a week. I need medication-assisted treatment, or else I'm going to go right back. They need that support to reinvigorate their lives. So medication-assisted treatment is a good opportunity for a whole variety of reasons.
Thank you, Mr. Hall.
Yes, Mr. Chairman. I believe that what is going on in Central and Southern Ohio is a signal for a national emergency. I think that opiates are probably the most addictive substance known to man, and that without a multi-layered approach, we're going to have hundreds of thousands of people in prison unnecessarily and dying way too early. Again, I think we need to take a multi-layered approach to this problem that includes things like drug court, intensive outpatient therapy, and medication-assisted therapy. I'm personally familiar with Suboxone. I think it's made a profound difference in our community. We need more of all of those things to combat this problem.
Mr. O'Keefe.
Mr. Chairman, we've heard a great deal about the success of and the advantages of Suboxone and treatment for patients. I mentioned in my testimony the concerns about the Drug Enforcement Administration and the fear of the Drug Enforcement Administration. As an example, back in July of last year, the Drug Enforcement Administration sent a letter to all physicians who were qualified to use buprenorphine for the treatment of opiate dependence. And they simply said, to accurately plan for and properly allocate resources effectively and efficiently, we are attempting to discern whether or not the data wave physician portion of your medical practice will need to be inspected. The letter was viewed to be fairly threatening by many physicians, and physicians objected to it. It, in fact, also included a request for information and a form which was never approved by OMB. And after objections by physicians, the DEA and the ONDCP, the DEA agreed that they would send out a letter clarifying. That clarifying letter said, speaking of the earlier letter, that letter was not intended to discourage or limit treatment services or imply that inspections were somehow the result of targeting for individual activity. If a practitioner chooses to return their DEA waived registration to DEA due to inactivity, DEA would simply remove that practitioner from our regulatory inspection program. Such action would prevent unnecessary on-site visits and enable DEA to employ its resources more efficiently. Most physicians took that as an invitation to turn in their right to prescribe Suboxone. As a result of that, of the 18,000 physicians in the United States who were at that time able to prescribe buprenorphine, 676 of them voluntarily returned their registrations to the Drug Enforcement Administration, resulting in 67,000 patients who were denied treatment because each of those could prescribe for 100 patients. These are exactly the kind of physicians that we're trying to recruit into the program. We want the physician who is treating only 1 or 2 patients to be able to treat that patient. But so long as they're threatened by the DEA, they have no intention of opening themselves to an inspection by a gun-toting DEA agent for the treatment of 1 or 2 patients. So I think it's a real deterrent. The DEA is a deterrent, significant deterrent.
Thank you, Mr. Pops. Proceed.
So first of all, hearings like this one today are very important, so thank you very much for your leadership on this. I was moved personally by Congressman Kennedy's remarks, and this idea that we tolerate suboptimal outcomes in the treatment of this disease while patients go to treatment facilities, quote unquote, and receive suboptimal care. It's a travesty. So as I said in my earlier comments, simply collecting data on the outcomes that one gets with Suboxone or with Vivitrol and publishing that data, disseminating it, and holding people to these standards would be a really important role that government can play. And then I also would amplify the comment about returning servicemen and women and veterans. Biotechnology drugs in general are often not on the VA formulary. And so the benefit of all this modern research, which we really are the leaders in the world here in the U.S., is often not translated into the people who protect us, and I think it's a mistake.
I want to thank each and every one of the panelists. This has been a hearing that will lead us into the next series of hearings that we're going to have on national drug policy. This subcommittee is charged with responsibility for oversight over national drug policy and for making recommendations. So I want to thank you for the role that you're playing in helping to better inform the members of this committee, subcommittee, and the members of Congress as to the directions that we might take that would be more effective for the individual who's struggling with an addiction and for the society at large. I'm Dennis Kucinich, Chairman of the Domestic Policy Subcommittee of the Oversight and Government Reform Committee. The title and topic of today's hearing has been Treating Addiction as a Disease, the Promise of Medication-Assisted Recovery. This subcommittee will continue to work in this area and look at a variety of treatments and to support those that are working to try to meet the challenge of this scourge of addiction. Thank you, gentlemen. Being no further business before this subcommittee, stand adjourned.